Hello, everyone. Thanks for coming. Some housekeeping stuff that I have to announce instead of clothing. Make sure you sign in. Please respond so we can better prepare for the next session. For online participants, please keep microphones muted unless asking a question and keep video turned off. Use chat feature in Blue Jeans if you have technical questions. Next week is going to be on the impact of toxic stress on lifelong health by Iman Sharif. The following week is Owning Attention, Applying Human Factors to Alert, designed by Christine Miller. Also, don't miss the first Tech Talk on April 7th. Tech Talk is a monthly seminar focusing on technical aspects of statistical, epidemiological, and bioinformatics methods and how they can be applied to medical research studies. Grab a flyer in the back of the room to learn more, and make sure you subscribe to receive emails for upcoming topics. And also see the full schedule on ACCEL website. And the previous presentations are available on our website, DE-CTR.org. So I'd like to introduce Dr. Mishka Terplan from Baltimore. He's a director of the Baltimore Behavioral Health System. He obtained his bachelor's degree in anthropology from the University of Chicago. He went to University of California, San Francisco for his medical education, and he's an obstetrician. He also obtained MPH from the University of North Carolina, Greensboro. And he does a lot of public health research and public health efforts to in the intersection of prenatal substance use issues and reproductive health. Please.
Thank you. Do I need to use the microphone? I need to use the microphone? Yes?
For the online people.
For the online people? All right. Thank you for inviting me. My name is Mishka Terplan. I'm trained as an obstetrician gynecologist. I'm also boarded in addiction medicine. I work mostly in Baltimore. And I'm going to talk about opioid use in pregnancy. I think I want to begin by thinking, if you were to go back in time, you're going to ask anybody on the streets of any American city between 1860 and 1900, if you were to ask them, what does a person with an opioid use disorder look like? And they would have told you it's a woman, it's a white woman, upper class or upper middle class, who had an addiction to either morphine or laudanum that was given to her by her doctor initially for the treatment of chronic pain, female ailments, etc. And you might know the term opioid eaters, and that's here. The woman on the right is drinking medicine. That's what was known as opioid eating. And in fact, substances that we think of as addicting, cocaine, opioids, etc., were explicitly marketed to women and children around this period of time. These so-called patent medicines, they weren't patented. Alcohol was the province of men, and this was the province of women. And if you went into a pharmacy on the top left, that's what a pharmacy would look like. A lot of glass bottles with different colored liquids inside of them. The liquids would be alcohol-based, usually with opioids in them. And laudanum was it's actually not a brand, it's a name of opioid tincture. And you can see it was marketed for babies. And I don't know if you can read on the bottom right, it gives you directions. Like 2 to 3 teaspoons for an infant, up to 30 teaspoons for an adult. And on the bottom right is actually a laudanum label from Baltimore, from the McCormick and Company. So it was manufactured in the United States. And just like with anything, if you expose enough of a population to a substance for which some people will develop use disorders, people will, and people did. And in fact, the first image that I've ever found of anybody injecting a drug is an image of a woman injecting morphine, and that's on the right-hand side there. The other way people took opioids were smoking opium, and that we associate more with immigrants, Chinese immigrants, but actually white women would probably the second largest population of opium smokers, as you can see from this photograph of an opium den. So around this period of time, addiction was understood as a medical illness and was treated as such. And that was based on the work of Dr. Benjamin Rush, who in the early 1800s codified alcohol as a public health issue and as a disease. And that model was applied to what was called morphinism. And clinics were set up. People received first morphine for the treatment, and when heroin came on the market, heroin was used for the treatment of morphine disorders. And the first instances of neonatal abstinence syndrome in the literature are from this period of time. And they were treated, actually, to some extent, somewhat similarly to how we treat it today. So to kind of compare, there might have been, these are some rough numbers that I kind of came up with from prior literature, but about 66 to 75% of all people with opioid use disorders in the turn of the 19th century were women. That was about 0.59% of the population. And now, today, we are in another opioid epidemic, and it is probably the largest opioid epidemic in the history of the United States. But it is by no means the first, and it's by no means the first to involve women and to involve children. So this is from the New York Times, and I'm sure most of you are familiar with this, but this goes from 2000 to 2014, and these are overdose death rates per 100,000 individuals. And you can see a decade and a half ago, deaths were really concentrated in the Appalachians, and from there, to some extent, it has spread. Today, approximately 130 people die from a drug overdose every day in the United States, and more than half of those are related to prescription opioids. And this equals the amount of life lost if you had a plane crash, like a 737 crash every 4 to 5 days in the United States. That's the volume of deaths lost to overdose. And this is the reason why. We have been prescribing more and more stabilized opioids for pain. Here you can see the green line is volume, weight of opioid sales in the United States that went from 2 kilograms for 10,000 people to over 7 in a decade. And in fact, CDC estimated that in 2012, there were enough opioid prescriptions written in the United States that every adult had a 30-day supply. And as prescribing increased, just like in the Victorian era, so too did drug treatment admissions, which is the blue line, and so too did overdose deaths. They all track. What is most incredible about this is how this has affected mortality rates for white people primarily. We talk in public health about bending the curve. Usually we mean it towards something good. Here you can see on the left-hand side, these are death rates for different countries over from 1990 to 2010. You can see it decreasing. It decreases for the U.S. whites, and then it levels off and increases. We've bent the curve on death, primarily due to poisoning or overdose, which is the slide on the right. There's been an increase in suicides, a slight increase in chronic liver disease, and a massive increase in overdose deaths, which has shifted mortality. And here, this is New York Times data. They looked at 60 million birth and death reports. And you can see the death rates stratified by race, ethnicity, and age status. And you can see for white women and white men in particular, an increase in death rates over the last 20 years. And here on the bottom, you can see death rates for overdose. Overdoses amongst Black Americans have always been far too high. But in the last 10 years or so, death rates amongst white men and white women have approached and exceeded that. So, this is what, this is a story. You see these in the news. Pill poppin' mamas. Many pregnant women take opioids, CDC finds. I like this slide because it's a pregnant woman, and the article is something about opioids, but she's smoking. Right? In fact, it doesn't relate to pregnancy. It relates to this data from the MMWR. And this was looking at prescription opioid claims amongst reproductive aged women. And somewhere between 28 and 40% of reproductive age women had an opioid prescription per year in this period of time. And this is also true in pregnancy, although a little bit less so. The top line there is the proportion of pregnant women who received an opioid prescription over time, and then the colored lines are by trimester. So we can see, regardless of trimester, about 6% of pregnant women per trimester are going to have an opioid prescription. But it varies actually by state. And overdose death rates correlate really well to overprescribing or prescribing rates by states. And you can see here, this is the states with the higher prescribing really are clustered around the Mississippi River. The New England is a little bit less, with the exception of Vermont, and then the West. So as people were prescribed more medication, more opioids, more women developed opioid use disorder and entered treatment. These are data for the proportion of drug treatment admissions amongst pregnant women in the United States for prescription opioids. And it increases from negligible in the early 90s to about a quarter of all drug treatment admissions today in the United States for women who are pregnant are for prescription opioids. There's another quarter for heroin. So 50% of all drug treatment admissions in the United States are opioid related. As pregnant women used more opioids, so too did the increase in neonatal abstinence syndrome, going from about 1 per 1,000 births to 3 to 4 per 1,000 births over the course of the early part of this century. I'll talk about this study a bit more coming up. Now, one thing that's happening in the opioid epidemic is, for lots of different reasons, the use of the physician drug monitoring programs, PDMP, these recent safe opioid prescribing guidelines, certain states have put them into place. CDC just released theirs 2 days ago. There's been a leveling off of opioid prescribing in the United States. And you can see that on the left-hand side, that's the number of people who reported use, a non-medical use of an opioid in the prior year. But the sort of converse of that is there's been an increase in heroin. And that's the red line, the number of people who said that they've used heroin in the prior year. And more concerning is actually overdose death rates associated with heroin. And that's on the right-hand side. You can see the blue line is overdose from prescription opioids. I actually had thought it was going to level off, but it ticked up again in 2014. But you can see a sharp increase in heroin. And interestingly, the death rate, the overdose death rate for heroin is increasing faster than the rate of individuals being diagnosed with heroin use disorder. And not everyone who dies of an overdose has an addiction to the substance, but this is probably not driven by heroin, but driven by, I don't know if you're seeing this here, fentanyl and other synthetic opioids, which are far stronger, far more potent than heroin itself. And as there's been an increase in heroin, who a heroin user has really changed in the United States. First of all, most people who use heroin today, their first opioid they used was a prescription pain medicine. And that's not what it was like in the 60s, 70s, or 80s. Most people used heroin during that period of time. The first opioid they used was heroin. But also we've seen a shift in the gender makeup of heroin users, and that's on the top right. In the 1960s, 10-15% of heroin users were women. Today it's about, we have achieved gender equality in heroin use in the United States. And the racial makeup has changed as well. In the 60s, 70s, the 80s, roughly 50-50 black, white heroin users. Today about 90% of heroin users are white. It is in the United States, and 10% are black. So overdose has also affected pregnant women. And these are data from the state of Maryland and from the maternal mortality review, which I participate. The last year for which we have complete death records is 2013. Maternal mortality is defined as the death from onset of pregnancy until 1 year after delivery. And in 2013, 30% of all maternal deaths were substance-related, almost all of which were overdose. And if you added, we created this category of behavioral-related deaths, which also included suicide and homicide, and those accounted for over 50% of all the maternal deaths in the state. And you think from a public health perspective, maternal mortality is an index of the health of a population. It's been used for over 100 years to measure health. And the traditional, historic causes of death being infection, preeclampsia, hemorrhage. Those are the minority of deaths now. It's behavioral-related, primarily substance-related maternal deaths in the state of Maryland. So this is in the news. This is a story from the New York Times now 2 years ago. Case explores rights of fetus versus mother. This was Alyssa Beltran. She had been in a motor vehicle accident. She'd gotten opioids for the pain. She had developed a problem with the opioids. She had been doctor shopping, obtaining them excessively, using them in an unhealthy kind of way. And at some point in time, she realized she had a problem, and she self-tapered. About 18 months after she had stopped using opioids, she became pregnant. She went to her first prenatal visit. It's part of the routine history and physical. They ask about, all sorts of past things. And she disclosed that she had had this problem with prescription opioids, but it was no longer a problem. She went home. 2 days later, the sheriffs knocked on her door, handcuffed her, arrested her, carted her into treatment, because Wisconsin's one of the states that has coerced treatment. You can force pregnant women into treatment. She spent 78 days in treatment. There's a whole lot of legal issues, et cetera. The state appointed an attorney on behalf of her fetus. She was denied representation herself. And ultimately, she was able to work her way out of that, delivered a happy, healthy baby without any problems, et cetera. And these stories are not uncommon. This is also from Wisconsin, and they're framed usually in a particular language. A parent's heroin addiction, a newborn's death sentence. No bystander could be more innocent, no damage, so helplessly collateral. When I see these, and I have a collection of these, it reminds me of another collection I have, which is from the crack cocaine era, right? Crack babies. The worst threat is mom herself. And I can talk a lot about the history of crack cocaine, et cetera. The bottom line is there's no such thing as a crack baby. But really what I want to illustrate is this idea of stigma, and that women who use drugs in pregnancy endure a particular stigma. And they're actually treated differently by the criminal justice system. You think about Alyssa Beltran. The salient feature of her crime was the fact that she was pregnant. If she had not been pregnant and disclosed that same information about having had an opioid, problem with opioids in the past, she would never have been arrested. So when we treat people differently based upon some characteristics, stigma is not the word that captures that. The better terms are really discrimination and prejudice. And those are the terms actually SAMHSA, the Substance Abuse Mental Health Services Administration, recommends we use when talking about this, rather than stigma. That's more of a euphemism. So the question is, why are pregnant women who use drugs discriminated against? And the answer is, well, it's complicated. It's to some extent, where I would say, and most people now would agree, failed war on drugs policies collide with state-level fetal legislation. These are data. This is the Guttmacher Institute puts this together. Interestingly, Delaware is not on their list. I don't know why. But they sort of classify states based upon how drug use in pregnancy is codified in the state statute. And the first column, criminal act, that is no longer the case. Tennessee, 2 days ago, allowed the law that had criminalized drug use in pregnancy to expire. It was not renewed. But there are 18 states where drug use in pregnancy is defined in state statute as child abuse. And there are 3 states for which it's grounds for civil commitment. And if you want to think that's like the punitive end of the spectrum, on the other side of the table would be maybe the more public health response. There's only 4 states which have explicit language prohibiting women from discrimination in publicly funded treatment programs. And there are only 12 states that in the state statute give pregnant women priority access to treatment. But it turns out you actually don't need state-specific legislation that criminalizes or calls drug use in pregnancy child abuse to arrest, prosecute, and incarcerate pregnant women for drug use. There's 2 types of laws that have been used, not just for drug, but for other related things. Feticide laws and chemical endangerment clauses. Feticide is if you murder somebody who happens to be pregnant and the fetus dies, it's an extra crime. These are laws designed to sort of acknowledge the extra severity of that murder. They were not designed to prosecute pregnant women who have a stillbirth, but they have been used for that. Pregnant women who've smoked cocaine and had a stillbirth have been prosecuted under feticide laws. Pregnant women one woman who attempted suicide and lost her fetus because of that was prosecuted under these sorts of statutes. So you don't need specific drug laws to prosecute pregnant women for these things. So I look at this legislation, I think this is unnatural. And it's unnatural to me because as an obstetrician gynecologist, we talk about the maternal fetal unit as it's bigger than 1 but less than 2. It's this complex, intimate biological entity. And developmental pediatricians and psychologists talk about mother-infant bonding as 2, but closer linked than any other 2 individuals, are in society. And these policies, in effect, cleave that. It's also discriminatory how these laws are applied. Actually, addiction is one thing that cuts across all strata of society. I tell medical students you can go into any field you choose to go into, you're going to take care of somebody with an addiction. And you can't say that about any other illness except maybe cancer. So it cuts across everything. However, poor women and women of color are far more likely to be screened, be tested, and be prosecuted if that's the local context they're in. Also, I'm not really going to show this, but I'm just going to say it. Generally speaking, we exaggerate the effects of illicit substances and we minimize the harms of licit ones when we think about fetal effects in newborns. And these sorts of policies drive women from treatment, drive them from prenatal care, etc. So I think it's important when we talk about this that we use the appropriate language. For example, Minnesota comes to the aid of opioid-exposed babies. I like that term. It's scientifically accurate. It's non-judgmental. And once I had a life in my hands, I didn't want to screw it up. That's a sentiment I hear from lots of people I've taken care of, and I think that's one of the things that makes actually working with pregnant women with use disorder very rewarding. And I'll talk more about that motivation. So I'm going to use the term substance use, which means just using something. Use disorder and addiction, I'm going to use those interchangeably. I'm not going to say substance abuse. It's an older term. It's pejorative, and I'm definitely not going to say the word addict. We shouldn't label people based upon their illness state. And if you think I'm being a little bit PC or something like that, there's actually randomized controlled data that support this. So these are 2 case vignettes, identical in all ways except one, the individual is referred to as a substance abuser. The other, he was referred to as having a substance use disorder. And physicians, there were 2 populations, physicians and general populace, were asked a series of questions after reading these. Those that read the case vignette where the individual is referred to as a substance abuser were far more likely to ascribe their condition to a weakness of their will, far more likely to recommend punishment, and far less likely to recommend treatment or anything within sort of a medical model. So the words we use actually influence how other people think about what we're talking about and how we think about what we're talking about. So I'm going to talk a little bit about what happens when pregnant women, or when women who use substances get pregnant. And these are data from the National Survey of Drug Use and Health, which is kind of considered the gold standard of prevalence in the United States as an annual survey weighted sample. And here, about 54% of reproductive age, non-pregnant women had a drink of alcohol in the past 30 days. And that's contrasted with 19% in the first trimester, 5 and 4. Cigarettes, about 24% of non-pregnant women smoked a cigarette. About 20% of pregnant women did in the past 30 days. And for illicit drugs, about 11% of non-pregnant women, reproductive age in the United States, have used an illicit substance in the past 30 days. Most of that is marijuana. And so you can see that, generally speaking, pregnant women use fewer substances than non-pregnant women. You can see that the use decreases through the course of pregnancy by trimester. Probably the greatest level of change is, from pregnancy to first trimester. And the magnitude of change differs by substance, with the greatest change in alcohol, the least in cigarettes, and illicit somewhere in between. So I look at those data, and to me this supports the statement that all pregnant women are motivated to maximize their health and the health of their pregnancy. And all women who use substances try to quit or cut back. And those who can't, they have a substance use disorder. In many ways, pregnancy is a natural experiment where everyone's motivated to change. Some people can, and those that can't, they have a substance use disorder. In many ways, continued use in pregnancy is pathognomonic for addiction. So when we're talking then, women who keep using have an addiction. And what is addiction? These are two definitions, one from ACCEL, the American Society of Addiction Medicine, the other one from NIDA. They both speak to brain disease. NIDA uses sometimes a hijacked brain hypothesis where the reward center, which is where dopamine is expressed, and then there are neurons that project to the frontal cortex that are dopamine, and the drugs sort of hijack that reward system. But really, addiction's a brain disease, but the visible symptoms are behaviors. So this is the DSM criteria for opioid use disorder. And just look at it and think about it from terms of my statement that women who keep using drugs in pregnancy have a use disorder. So craving, continued use despite persistent or recurring social or interpersonal problems, recurrent use of opioids in physically hazardous situations. Really, anyone who keeps using will meet at least two of these criteria. I want to make the point that not everyone who uses a drug becomes addicted. In fact, the minority do, and it depends on substance. The most addicting, quote unquote, being nicotine, followed by opioids, and you go down from there. I also want to differentiate addiction from dependence or tolerance. And this is important when we talk about NAS. Dependence and tolerance are like pharmacologic and biological principles. Tolerance means you have to increase the dose of something to maintain the effect. And dependence means when you stop using it, you have symptoms of withdrawal. These are true of opioids, but these are also true of hypertensive medicines. These are also true of SSRIs. In and of themselves, addiction is a brain disease. The symptoms are behaviors. Dependence and tolerance are not behaviors. So, we're talking now about women with a use disorder, opioid use disorder in pregnancy. And what else do we know about them? We know that they have a high burden of mental health conditions. Roughly 2/3 have a co-occurring disorder. The most common being mood disorders or anxiety, followed by PTSD. Women with opioid use disorder in pregnancy have a large burden of childhood trauma, in particular sexual and physical abuse. Depending how you ask the question, If you ask it well, 90% of those women, of your women, will say yes, they have it. Roughly half, sometimes more, are in a current or recent violent situation. 80% have unplanned pregnancies. This is data from Loretta Finnegan when she was in Jefferson, and about 70% of the women in her clinic then, their parents had opioid use disorder. So you think about they might have experienced unpredictable parenting models that they might be doing with their children. It's also higher rates of poor nutrition and smoking. And polydrug use is common. In other words, women with opioid use disorder have a unique set of needs. And when we think about what treatment should look like for them, treatment should really address all of these different needs. So the gold standard care is comprehensive co-located services. Like at Hopkins has a Center for Addiction and Pregnancy, Jefferson has a Mater Clinic. There's a couple, there's like, maybe 5 to 10 of these in the United States. That's the ideal. The second sort of model would be very important, very close collaboration between substance use disorder treatment providers and prenatal care. And that means consent forms, team meetings, warm handoffs. I'm happy to talk more about how you build something like this in the absence of the Cadillac version. And part of really important is screening, is early identification, in part because I showed how most women change their behaviors during pregnancy, and most of that change happens early. So that means whatever else you can add on to that is essential. So identifying women earlier in the course of pregnancy and earlier in the course of your care with youth, such that your interventions can maximize that behavior change. And when I talk about screening, I'm mostly going to talk about screening women in prenatal care for substance use and use disorder, but I also mean screening women who are in drug treatment for pregnancy intention, right? Identification at birth. Martha Clark, who worked for DSS in Maryland for a long time until she recently retired, she used to always say, identifying substance-exposed newborns at birth is 9 months too late. So, universal screening is what's recommended, and that means everybody gets screened. And the reason for it is risk-based screening. 1, you miss people, and 2, perpetuates that stigma, that discrimination that we talked about before. It operationalizes discrimination, risk-based screening. Now, sometimes when I talk to obstetrician gynecologists, you want to see, like, these on the top are things we screen for in prenatal care and their prevalence. Just because something is rare doesn't mean it's not important. But if you look at substance use, is as common, if not more common, than most of the things we already screen for. But there's reasons women might not choose to disclose use to us. They might have had previous bad experiences, fear of CPS, don't want to be discriminated against, or sometimes they don't consider their use problematic. And this means there's a life course, sort of an arc sometimes to addiction, right? Where people use, they develop a problem, and then slowly that problem manifests itself and it grows in ways that relationships fall away. We get trouble with work, maybe trouble with the law. Sometimes some pregnant women actually meet criteria for a use disorder, but they have not experienced any of those negative life events of addiction thus far. And this is the first time they're being told that an authority, a physician is telling them, I think you have a use disorder. So they might not consider their use problematic. So the best practices for screening, and by screening I mean talking to a patient, and I also mean using an instrument, is you want to embed them, normalize them, and I think it's really important to ask permission. If you say, is it okay if I ask you some questions about smoking, alcohol, or other drugs, and she says no, that's not okay, great. You don't push it. Because women with use disorders have probably been stigmatized in the healthcare system before and are used to being lectured to, et cetera. And if you actually are like, okay, I respect you, I'm not going begins a therapeutic alliance, which can be really, really helpful down the road. The thing about prenatal care is that it's not a one-time visit. You see people all the time. So the importance of building a therapeutic alliance early by treating her with dignity, which means asking permission and listening to what she says, is really key. So there's many different instruments. Some have been validated in pregnancy. There's very little head-to-head data. There's a CDC-funded trial which is looking at comparing a bunch of different instruments, which just started recruiting. So in 5 years, I'll be able to say this one instrument seems to perform a little bit better than that one. But a validated instrument is best. And what about urine? Is urine a screening test? Remember I said like addiction is a brain disease and the symptoms are behaviors? Urine doesn't test behavior, right? Urine tests the presence of metabolites in the urine, and they vary by substance, they vary by time, and actually prescription opioids at most are going to be negative in the typical urine screen without confirmatory testing. They're plagued with false positives as well as false negatives. Urine is very useful. We use urine in drug treatment to monitor, medication adherence and things like this. But as a standalone screening test for what we're talking about, not only is it inadequate, but it's also probably unethical unless the patient consents. Do women consent for urine drug testing on labor and delivery here?
We now are screening everybody.
Okay. So you know why people have to consent explicitly for urine? So in the late 90s, University of South Carolina Medical Center was testing poor black women's urine for cocaine, and if they were positive, they were calling the cops, and the cops were coming and arresting women off the labor floor. There was a class action lawsuit that went all the way to the Supreme Court, and in 2000, the Supreme Court ruled that that was illegal search and seizure, and that because the women had not given consent for the urine test, and vacated all the sentences. Some 40 women were incarcerated for that. And since then, you're supposed to have explicit consent on labor and delivery. To me, the question becomes, since we do sometimes urine drug testing during prenatal care, if that's the law for labor and delivery, ethically, to me, it would apply also to prenatal care. So we should be asking consent before we test urine. So how well do we do with this? These are PRAMS data from the state of Maryland. Only about 70% of women postpartum said any healthcare provider talked to her about drinking or smoking. About 60% said somebody had told her something about illicit drug use. And to me, the most damning is only 51% of women who delivered a baby who are part of PRAMS in 2013 said somebody had talked to them about physical abuse. So how do we treat addiction? We treat it both behaviorally and pharmacologically. Behaviorally, these are the stages of change. The idea is you identify where somebody is on here, and the behavioral treatment moves them through preparation into action, and especially maintenance, which would be like the recovery period. For opioid use disorder, the standard of care is medication-assisted treatment, either buprenorphine or methadone. And there's lots and lots of reasons for this. One is these are both long-acting opioids, so you have a stable intrauterine environment without the periodic withdrawal. So people who inject heroin inject anywhere between 3 and 8 times a day. And really, when people use heroin, they're not getting high. They're self-medicating withdrawal. And their withdrawal, the fetus experiences. It's the repeated withdrawal that is probably worse than the opioid exposure. So it's a stable intrauterine environment. These are also very good medications at reducing cravings. So people then aren't thinking about obtaining and procuring substances. They can actually attend to the behavioral work of treatment. They're associated with increased weight gain, gestational age at delivery, prenatal care adherence. Clearly, if somebody's no longer injecting drugs, they decrease their risk for HIV and hepatitis C, both of which can be vertically transmitted. Adherence with treatment also decreases the risk of overdose. And MAT is supported by every single professional society that's ever weighed in on the topic. I showed you that slide about what states do vis-a-vis drug use in pregnancy. This is in contrast to what the federal guidelines are. The opioid treatment guidelines from the feds actually state that pregnant women should be given priority access to treatment. In fact, pregnant women, they're considered a special population along with people released from the criminal justice system recently and those with HIV. In that they get not only priority access, but the criteria by which you get able to receive methadone is lessened. Do you guys know the opioid antagonist, agonist, partial? So a receptor, any opioid is anything that binds to the opioid receptor. An agonist is like a key that opens the door, turns on the opioid system. Antagonist locks the door, and a partial opens the door a little ways, but not all the ways. Buprenorphine is a partial agonist. Methadone is a full agonist. Heroin's a full agonist. OxyContin is a full agonist. And naloxone and naltrexone would be antagonists. So these are our two medications primarily that we use in pregnancy. The important thing to note is really that methadone varies by individual. Body clearance varies. This is a morbid way to talk, but there's really only two ways you can kill somebody in addiction medicine. One is you cannot medicate their alcohol or benzo withdrawal. That will kill somebody. And the other way you can kill somebody is give them too much methadone too quickly. So the adage for methadone is start low and go slow. And that's because it varies and it takes a while to build up a stable rate. Buprenorphine is a completely different distribution way of doing it. It can be office-based practice as opposed to traditional OTPs. And it comes in two formulations, a monoproduct, which is just buprenorphine, or sometimes the combination product, which is with naloxone. Naloxone is a full antagonist. It's there so that if somebody were to crush or dissolve the tablet or the film and inject it, the naloxone is activated, and that then is a block. It's not orally active. In pregnancy, in the United States, we just use the mono product. In other countries, they use the combination product, and a lot of people have experience using combination product, and it's a reflection of the FDA system rather than a risk of that substance per se. So which medication? We had a randomized controlled trial looking between these two. Andre Jones at Hopkins was the PI for it. And the main outcome was neonatal abstinence syndrome. And basically, those moms who were randomized to receive methadone, their infants had received more medication for neonatal abstinence syndrome, spent more time in the hospital, and had more days of being treated for it. However, the women randomized to the buprenorphine group were more likely to leave the study. About 30% attrition in the buprenorphine arm, as opposed to less than 20 in the methadone arm. And this probably has to do with the pharmacologic nature of the difference between these two substances. When you induce somebody on buprenorphine, you precipitate withdrawal. Withdrawal is uncomfortable. The formula that this study used, because it was still when we were learning how to use buprenorphine in pregnancy, was rather conservative, was slower increase in buprenorphine than we would use now. People were uncomfortable and they left the study. So this sort of summarizes it. Methadone might have better treatment retention. There's no precipitating withdrawal. And methadone is probably a better choice for individuals with a severe opioid use disorder. So there's a lot of, I'm going to move now to the sort of controversies, so to speak. Non-pregnant people on methadone or buprenorphine, but more methadone, we wait until they're symptomatic from withdrawal before we increase the dose. For pregnant women, we don't want to wait that long. Now, there's opioid withdrawal scores that are used, and the symptoms of opioid withdrawal are actually kind of similar to the symptoms of early pregnancy. Nausea, sweaty, poor sleeping, etc. I've always been curious just to use the opioid withdrawal scale in a population of non-opioid using pregnant women to see what the scores would be. So it's tricky, right? This is the art. Third trimester, due to the physiologic changes of pregnancy, sometimes you have to increase the dose, maybe split the dose, but this does not mean automatic dose increases. So this was in the news. I don't know. This came out like through OBGYN News. This was on ACOG listservs. The opiate drug detox appears safe in pregnancy. This was based on a poster that was presented at the Society for Maternal Fetal Medicine a couple of months ago, looking at 301 women who were detoxed at various points in time in pregnancy. And by safe, they mean there were no fetal losses. The problem, and these, I'm looking, this should be published. I'm looking forward to it, but I don't like when posters get a whole lot of media attention because you can't really evaluate the study. There's a lot of questions I don't know about this. But basically, if you look at the bottom here, you can see that their relapse rates were either 19% or 71% or 15%, depending on the context of where the detox happened. And this is really the issue, is that the problem with medically supervised withdrawal, which is a euphemism for detox, is that it leads to relapse. This is a study on your left-hand side, and in it there were 95 women, and they called it successful in that 56% were successfully detoxed. 44% underwent the detox and tested positive for illicit substances at the time of delivery. So 44% relapsed. I don't call that successful. Continued illicit opioid use is associated with overdose, with HIV acquisition and transmission, non-adherence with prenatal care, etc. So, to summarize medically supervised withdrawal, we're talking about an acute intervention for a chronic illness. That's a clinical mismatch. That doesn't make sense. It leads to relapse. It's not supported by guidelines, and maternal dose reduction to prevent NAS, which has been tried over and over again for decades, doesn't work. Do all of you know what neonatal abstinence syndrome is? Yes? So what it's not is addiction, right? Babies are not born addicted. They're born dependent. That's why I went through the difference between dependence, tolerance, and addiction. They have withdrawal when the opioid is removed. It's not addiction. Addiction, the symptoms are behavior such as compulsion, or lots of time spent obtaining and procuring of substance. Newborns can't have those behaviors. And it's a chronic illness, and chronic diseases really can't be present at birth. So ACOG uses this terminology that NAS is expected and treatable consequence of opioid exposure in utero. And this language was picked up by the Government Accounting Office when it did an audit of all the federal agencies in response to the prescription drug epidemic. And there are no long-term negative outcomes. We can talk a lot more about that if you wish. It's not just an opioid thing. Other substances, such as SSRIs, tricyclic antidepressants, newborns exposed to those substances display behaviors and can be measured on a Finnegan scale to have a withdrawal syndrome. There's a lot about NAS that affects its severity, more beyond the opioid. How we assess, where we treat the babies, right? Placing them in a neonatal intensive care unit environment. The weaning protocols, there's a huge heterogeneity in the United States of what medicines are used for the treatment of NAS, some of which are better than other ones. Also, we've learned there's some genetic variability. One, to the opioid receptor itself. There's different methylation sequences that can happen to the opioid receptor. Newborns that have that have far worse NAS. There's also genetic differences in terms of the placental transfer of methadone, which has been the most studied, or other opioids. So depending on the genetics of those things depend whether or not a newborn develops NAS and how severe it is. We also know that women who smoke cigarettes, who also use benzos, who might be on SSRIs, NAS is worse for them. And we know what works, aside from medication, non-pharmacologic medicine things, skin-to-skin contact, breastfeeding, reduce the severity of NAS, its duration, and the amount of medication needed. So I want to go back to this. This is probably the most cited article on NAS in the history. And Stephen Patrick looked at these data, big increase. And the point really on the top red things, the cost of care for a newborn in the United States in 2009 was about $9,500 but it was about $54,000 for a baby with NAS. And the proportion of births of NAS babies in the United States paid for by the Medicaid system has increased from about 65% to about almost 80% in the last decade. So this cost of care is driving a lot of attention to this topical area. But I want to ask whether or not just because something costs a lot of money, that doesn't necessarily translate into the disease being more severe or it being more of a public health crisis. Cost is very important to consider, but a lot of the cost of care in NAS babies is a reflection of where we take care of them. They go to a neonatal intensive care unit. They're separated physically from mom. Some NICUs don't allow breastfeeding. There's less skin-to-skin contact, bright lights, lots of noise. It makes their NAS worse. It makes them need more medicine for it. It lengthens their stay, all of which drives up cost. There's some examples, mostly from Canada, of rooming in for NAS babies. So instead of going to the NICU, the baby stays with mom in the same room. And what we know from those data is that they have actually their 50% decrease in the risk of needing to be treated for NAS. If they are treated, they're treated for a far shorter period of time. Therefore, they stay in the hospital less. And most interestingly to me, rooming in increases the likelihood that baby's going to go home with mom. So I thank you for this opportunity to come and talk here today. And I realized, I've spent a lot of time in what I call the pregnancy box. Right? We talked about substance use in pregnancy. And that's important. But I think it's really important to step back from that and to think about addiction and from pregnancy from life course perspectives. Because really what we're talking about is not addiction in pregnancy, i.e. it's not pregnant women who then develop the behaviors of an addiction while they're pregnant. I've never seen somebody do that. I've seen people relapse during pregnancy, but I've never seen de novo addiction in pregnancy. What we're talking about is where the life courses, reproductive health and the substance use and use disorder life courses intersect. Because what we know about addiction as a chronic disease, we know a little bit how to prevent it, we definitely know how to treat it, but we don't know how to cure it. So the goal is that life course, lifelong symptom management. From a reproductive health perspective, this is marker data. The typical woman in the United States spends 5 years pregnant, postpartum, or trying to get pregnant. So that means she spends 30 years trying not to be pregnant. So we have to put these two kinds of things together, right? And think about substance use and use disorder in a life course perspective, which means identifying women in treatment or during non-prenatal care for risk and what their pregnancy intention is and providing them with contraception if they need to. And it means thinking about women who are pregnant and in prenatal care and assessing them for use and use disorder. Because really, I've been trying to think of what's the best analogy for addiction in pregnancy, and I kind of think it's seizure disorders, right? Seizure disorders are life course. There's medication. Medication improves seizure disorders, but the medicines are associated with birth defects, right? Nobody would ever approach a pregnant woman with a seizure disorder and say, you should stop that medicine because it might cause a birth defect. Because we know untreated epilepsy in pregnancy is far worse. But we often talk to pregnant women, you sure you want to be on that methadone? your baby's going to have NAS, which is a lot better to have than, some of the birth defects associated with the anti-seizure medicines. So probably thinking about the, addiction in a life course perspective means that we don't think about it as something that people can just stop during pregnancy. Because really what I want to avoid is this. And these are data focused on NAS from Florida State. And these were 3 different hospitals looking at all the NAS babies. These are moms who delivered babies who developed NAS. Only 40% of those moms were in treatment. And even worse, less than 10% of moms whose babies developed NAS in these 3 hospitals in Florida received any counseling or referral around drugs at the time of labor and delivery. So this is a failure of a system. This is looking way too narrowly at the problem and not thinking about it in a public health context. So these are my concluding slides. I hope I've shown that I think pregnant women can manifest motivation to maximize their health. Most stop or quit use in pregnancy, and those that don't have a use disorder. Women with substance use disorder have unique sets of needs, and care and experience discrimination, and care needs to be to match those needs, be compassionate, non-judgmental, comprehensive, and coordinated. And really, if we want to talk about preventing substance-exposed pregnancies, that actually means decreasing unplanned pregnancies, which means increasing access to reproductive health services and contraception. And that's it. Thank you very much.
I wonder about one of the things we think of as adult cardiologists, we think about pregnancy as the first stress test.
Yes.
And we learn a lot about hypertension.
Yep.
From hypertension or diabetes during the
Yep. The window.
So here's another kind of stress test for our women. What do we learn about their subsequent life course of substance abuse, and how can it help us do better beyond pregnancy?
Well, I think really where we lose people is in the postpartum period. You look at the overdose death data from Maryland State, most of those deaths happened in the postpartum period. We actually do a pretty good job of, generally speaking, with the people that we hold during the course of pregnancy, they deliver, and they fade away. And so relapse, you think about the postpartum period, is most women quit or cut back, 80% resume use postpartum. Now, many people look at that data and they say, oh my God, it's hopeless. I look at that and I say, you've got to be kidding me. Like, the only intervention is pregnancy, and you've got a 20% abstinence rate? That's incredible. That's better than most behavioral treatments that we have. So I think that it's important not just to look in the pregnancy box, but to think about the postpartum period and try to, and the question to me really is, how can you maintain that positive behavior change that women manifest during pregnancy? We're not talking about people with addiction per se, but just healthy, smoking less or not at all, not drinking unhealthily. How can we take that motivation, that change that happens in pregnancy, and how can we continue it through the postpartum period? I don't know the answer to that. But that's, I think, a place of intervention and thinking is in that window. Yes?
One of our online viewers would like to know if the co-administration of opioids like morphine or oxycodone during hospitalization with Suboxone will precipitate acute withdrawal.
No. So good question. So basically, let's talk about labor. I took those slides out. The labor management of women on medication-assisted treatment. Labor is painful. When people come in on methadone or buprenorphine, that should be considered their baseline. You should, so that you want, and pure agonist therapy, which would be Vicodin, Percocet, fentanyl, that's completely fine. It's the partial, what's going to precipitate withdrawal would be a partial agonist analgesic management. Yes?
Slide about the poster citing it being safe to detox women who are pregnant. That runs counter to all the data I've seen to date about pregnancies being lost or really at high risk when you medically supervise withdrawal. Is that was that study? I know you said the study you don't really have a lot of details on. Is that being widely published?
Well, so it's a poster, and I'm hopeful that the authors will be emboldened by all the media attention they've got to turn it into a manuscript in the peer review literature. What they mean by safe, I think, means that there was no fetal demise. So there's been this language in the ACOG guidelines, especially around detox, that detox is potentially dangerous because of fetal loss. That is not really based on very strong anything. It's based on data from the 70s looking at cortisol levels and amniotic fluid of women who were withdrawing and that they were elevated. And then the hypothesis that that's associated with the risk of loss. So we've focused probably too much, as the college has focused too much on this, so that somebody can say, look, we detoxed a bunch of women and no fetuses were lost, hence it's safe. But really, to me, it's not, that was never the concern. The concern is relapse. And yes, anybody can take somebody who uses opioids, and in a controlled environment, over 5-7 days, you can taper it down such that they are going to test negative for drugs and not display any withdrawal symptoms. But you've done nothing to address the behavioral context of the illness. So unless you treat that, they are more often going to relapse. So I think that's what they meant by safe, is we didn't know fetuses died. Other questions? Yes?
You had some slides of the, I think the case of the mother that was, you could just go back to that. I just wanted to point out something.
Like the one from the New York Times or the other one?
Well, there were two.
Yeah, well, we'll find them. Oh, it's up here. There's two here.
You're close. There it is.
This one? Or that one? Uh-huh.
So, if I'm not mistaken, this is a picture of a mom that was that had substance use disorder specific to heroin. Am I correct?
No, she was on prescription. She was never diagnosed with a use disorder, but she was using prescription pain medication in a manner not prescribed.
Okay. And then the next picture. This was a mom that was using heroin?
Yes.
Okay. Can you go one more further? And my point is that the images that are used have strong political impact. And so when we are showing non-minorities, it's a very happy mom who seems to be well caring for herself. But when we talk about minorities using these substances, it's a very different depiction.
Oh, yeah, and that's what was really underlying, I think. This is pregnant women have been, had addictions for as long as kind of those two things have been around. But this is where I think the real history of some of the negative portrayals of pregnant women and opioids, the history of that has its feet firmly in the crack baby epidemic, which was about black women, about poor black women, about welfare, and actually not very much about the science. So in the very beginning, there were a couple of articles. Ira Chasnoff wrote one that was in the New England Journal of Medicine, which always gets you recognition, in which he described amongst 30 cocaine-exposed newborns catastrophic outcomes, neurologic, teratologic, like just horrible. And that spurred all this research, and people found in the beginning horrible, horrible, horrible things. And it wasn't just these defects, it was also that these children were going to grow up to be uneducatable, bankrupt the educational system, etc. And then, retrospectively, even 10 years after that, people started to look at the literature again. Even meta-analyses of stuff from that time do not show an effect. If there's any effect, the primary persisting effect of cocaine in pregnancy is abruption, which is rare. And it's a little less rare, but it's still rare in cocaine users. But so where did all of that come from? Where did that science of horrible negative outcomes come from? Well, it came from bad science. A lot of these studies weren't blinded. people were reading all sorts of horrible things in the public media about crack cocaine, how it made, people crazy, made moms like not, hate their children, not be able to display love, all of this sort of stuff. And that influenced actually what scientists were observing in the clinical research encounter. And it's a real cautionary tale. I mean, it's a tale for one, for good methodology, two, to just use caution, and three, how these narratives get entwined and how harmful it can really be. And this is, we're seeing now, we see some of this legacy of these sorts of things. It was really where, and what we didn't talk about, which is what we should have talked about, nobody ever used the term poverty babies, right? We, crack cocaine overemphasized, the chemical exposure risk in utero and completely underemphasized not just the caregiving environment, but the actual structural context of poverty and racism and being, and that's really what we should have been talking about. But people would rather talk about the chemical exposure and, et cetera. But I agree with you. No, there's some powerful, messed up images.
I have one last question on a different topic. It has to do with breast milk.
Mm-hmm.
Do you think the cause of the reduced incidence of neonatal abstinence syndrome in mothers
probably, yeah.
Do you think they were potentially receiving a dose of opioid during the breastfeeding that's reducing the withdrawal?
That's a great question. The answer is there could be there's a little bit in there, but we know skin-to-skin contact in the absence of breastfeeding has most of the effect from breastfeeding can be seen in just skin-to-skin contact in the absence of breastfeeding. So it's probably, again, it's not a chemical exposure, it's a social, environmental, contextual effect. Other questions? All right, thank you so much.